Again, thank you, Melissa, for the opportunity to present to this group. It's certainly been an interesting experience being able to sit in on all of these talks and hear this diverse and very civil conversation that I think you had the wisdom to try and arrange and engage such wonderful people with, again, as I say, such a diversity of opinions and perspectives that we've been able to hear today. Melissa asked me to talk about alternatives to MAID, and we had a fair bit of discussion about the fact that the way that I approach this and my interest in this issue is really from kind of a broad perspective of suffering and understanding the nature of suffering. I mean, that's the area of work that I've been in for years. So I don't see myself or identify myself as a MAID researcher, but rather a palliative care researcher who is interested in what I call the experiential landscape of end-of-life care. And so I've called this particular talk addressing existential or spiritual suffering in the context of a wish to die. Thinking about a subtitle for my talk, I kind of paraphrase something that I shared with the Special Joint Committee to Parliament, who are looking at medical assistance in dying, and that is that I suggested to them that in dealing with suffering associated with a wish to die, MAID is not, cannot, and should not be our only card in the deck. And so I really don't plan on talking about the MAID card per se. I think we've heard extensively from people who have extensive experience in that particular area, but I plan on at least alluding to other cards in the deck that we should be aware of. Let me kind of back up by saying I've been at this for maybe a longer time that I'm becoming comfortable admitting. I met with a group of residents the other day, and I looked around and realized that I started doing this largely before I think any of the residents were born, which is really startling. But I came into this work, I sort of see formally back in, I think 1987 is the year I would say I formally began my professional career in palliative care, and then in the early 90s started to publish some of the very early studies that were broaching this whole topic of whether or not it was ever normal for people nearing the end of life to wish life to be over sooner. And again, this precedes, it looks like somebody's got their microphone up. And so these studies and these inquiries, of course, preceded Carter by several decades. And at the time, we were looking for people who would, in the context of approaching end of life, would reflect on this notion of whether or not they ever wanted life to be over sooner than later. So not necessarily the coveting of a hastened death or an assisted death, but just the wish that their life be somehow shorter than longer in duration. And we published some of these early seminal studies in the American Journal of Psychiatry, in which we looked at the prevalence of desire for death in the terminally ill and looked at comorbidities with desire for death, which suggested a high prevalence of things like syndromal depression, a paucity of social support, and a high degree of pain. In fact, about 80% of patients in our cohorts of those who wanted to die reported pain of moderate severity or greater. Also, in those early years and in those years before I segued into a large program of research on the issue of dignity towards the end of life, we also were one of the first groups to broach this issue of will to live in the terminally ill. And so we were able to follow people sequentially over protracted periods of time to measure this seemingly ephemeral construct like will to live, and this was published in the Lancet again in the mid-90s. And what was meaningful, and this is a particular case example taken from that data, is to show that when you look at this 80-year-old woman with end-stage colorectal cancer, that she is able to meaningfully relate to the construct of will to live, and reports by virtue of a high score on her ESS that initially, when she came into this study, she had a paucity of will to live, which then improved during the time that she was in palliative care. And then towards the end of her life, will to live became much more fluctuant or much less reliably reported. And a time when patients were no longer competent, we stopped gathering data. And then what we were able to do with this kind of data is to start to look at some of the relationships, some of the correlations between things like, in this instance, something as spiritually based as will to live, and something as somatically or physically based such as pain. And so we see the superimposition of her will to live and her experience of pain, and we can see in this instance at least that these two things seem to do this kind of very intimate dance with one another, a tango, if you will. So it might be the case that as her pain improves, so too does her will to live, or conversely, as she is able to avail herself of all of the benefits of palliation and support and the spiritual supports that are contained therein, that her experience of pain begins to improve. Now, in some ways, presenting at today's presentation, which has been, very much focused on MAID, feels like a bit of a full circle moment for me, because although I've never been a MAID researcher, my research has certainly very much been influenced by what I've learned about MAID, and particularly when I was beginning this kind of work, we started to look at the experience of investigators in the Benelux countries, and we had the benefit of one of those esteemed colleagues here being present with us. And I have looked at those studies. Paul Vandermaas, for example, was one of the earlier investigators who was commissioned by the Dutch government to look at what they called MDEL, or the medical decisions to end life, and was able to report, that, depending on whether it was euthanasia or assisted suicide, that 2 to 3% of Dutch patients were in fact ending their lives, most of them as a result of euthanasia, and then a smaller minority because of assisted suicide. But the more interesting piece for our research group, and the piece that really led to me segueing into the whole area of dignity, which I'm going to spend some time talking about, which of course has implications in terms of spiritual interventions, was that when Vandermaas interviewed Dutch physicians who were involved in acts of euthanasia or assisted suicide, and asked Dutch physicians why they had acquiesced to these requests, in fact, it was loss of dignity more so than any other reason, according to these Dutch physicians, as to why their patients availed themselves of this life-ending measure. And so that was the first time that dignity was kind of first place on our research radar, or empirical radar, if you will. And we concluded that if dignity is worth dying for, then dignity is worth studying. And at that point in time, there really hadn't been any studies in the literature that had put an empirical lens on dignity. Dignity was talked about a great deal in the literature, very politicized, and essentially used as a trump card to support whatever position, contentious as it might be, you had in saying that either euthanasia is or isn't a good thing because ultimately this is a dignity issue, or on the opposite side of the political fence, this is an affront to human dignity. And so we tried to step away from any kind of political or philosophical agenda and said, as researchers, let's find out what patients think about this. And so we studied large cohorts of dying patients, and we, in one of the early studies, we essentially divided them between those whose dignity was intact versus those whose dignity was fractured, and indeed found that dignity seems to be an important construct, an understanding the notion of dignity. And I heard some earlier presenters say today that we need to put dignity on our radar of things that we need to be mindful of in terms of setting a research agenda, in terms of understanding this experiential landscape that is marked by a wish to no longer go on living. And in fact, when you look at patients near the end of life, and all of our patients were in palliative care, less than 6-month life expectancy, indeed, those with a fractured sense of dignity had more difficulties with physical symptoms marked by pain or difficulty with bowel functioning, or even things as physically based as how they appeared. These intimate dependencies of care, bathing, dressing, toileting, amongst people with a fractured sense of dignity, these were profound things that undermine their sense of whether or not life continued to have value. And as I pointed out, there were these psychological symptoms: a desire for death, loss of will to live, feeling depressed, hopeless, or anxious, which in some ways kind of lends empirical validity to the results that van der Maas had pointed out, that perhaps, people experience a lost sense of dignity, ergo there's an undermining of their desire for death and a heightened or a lost will to live, along with these constellation of symptoms that then in turn lead to requests for an assisted death. One of the profound findings, and I've always sort of thought of it as kind of this epiphany, was that when we started to look at some hierarchy of importance in terms of what predicts intactness of dignity more so than any other thing, what we found is that the way people perceive themselves to be seen, the perception of how you were seen, which led me to find this wonderful etching by M.C. Escher. And I had published an article in the Journal of Clinical Oncology called "Dignity in the Eye of the Beholder." And basically the message, and I think the importance when we're talking today about suffering and how to approach suffering, is for us all to be mindful. And this is what this photograph is meant to show, that the metaphorically, the image that patients are looking for in the eye of the healthcare provider is one that needs to be affirming of personhood. And that's why this is a self-portrait in which you see a middle-aged man who has his photographs, his books, his pictures. It is an image that is reflective of the whole person. And so in terms of a therapeutic stance, when we talk about the wish to die or no longer go on living, patients no longer feeling like who they are as a person, providing a stance that is imbued by this notion of affirmation and providing affirmation is of critical importance and something I think we should be mindful of. I think the work of Cassel has already been mentioned, but I thought I would cite it here because Cassel actually makes a linkage between suffering and dignity by saying that suffering is a unique distress of persons whose intactness or integrity is disrupted or destroyed. And that's something that Cassel was very much known for, and a huge contribution he made to our understanding of suffering, that suffering has to do with persons, with whole persons. And when persons are under assault or feel some aspect of personhood is under threat of disintegration, suffering ensues. And what Cassel went on to say is that it flows that the loss of dignity may incite suffering, as do other injuries to persons. So when I was thinking about today's presentation, I started wondering, how do we try and put the pieces together? And again, in my discussions with Melissa beforehand, I'd been saying, we need to think broader than MAID, and we need to think broader than just loss of will to live. And so I started to try at least to put together the various different pieces that might describe kind of this existential map, if you will, so that we could hopefully begin to include, if not this map, maybe some variation thereof, so that we could start to expand our dialogue around the wish to die and MAID, to start to include issues related to suffering and how suffering might ensue. So to briefly kind of describe what I've done here is to say that initially all of us, by virtue of being mortal and being vulnerable, experience various different kind of assaults. In medicine, of course, the assaults that we're most familiar with are physical assaults. And so we talk a great deal about illness or injury, associated debilities or subsequent dependencies that may result from that. But of course, being human, we're vulnerable to a wide variety of assaults, psychological assaults that may present as depression or de novo anxiety, assaults on cognition, again, that undermines sense of wholeness or intactness of person, delirium, dementia. There may be existential assaults. We may experience a loss that undermines our sense of being whole, that can ensue, for example, with grief. It may be an assault on our spiritual well-being, finding ourselves questioning our faith or beliefs, or a loss of sense of meaning and purpose. Or there may be psychosocial assaults, and again, thinking about the determinants of health. And these things may be relational, they may be financial, they may have to do with the change in the structures that support us, like fooding and house security, or even in social status. So if we then start to look at issues related to dignity or personhood as described by Cassell, we have to understand that all of those things that I've mentioned are ways of inflicting injury or assault on these various different aspects of personhood. The model of dignity, which I'll show you in a better slide in a moment or two, looks at various elements of dignity or dignity-related distress. In other words, in a model of dignity in the terminally ill, we have looked at the various components that dying patients have identified that either help bolster or undermine their sense of dignity. Very much related to that, Cassell has pointed out these various dimensions of personhood, and for those of you who are familiar with his work, you will recognize these. He talked about, we have a past life and a family life, cultural roles, instrumental dimensions, and so on and so forth. And what he pointed out is that any one of these dimensions of personhood is vulnerable to injury. And when injury ensues, suffering results. Now, how does that relate to existential distress? And I'm grateful to my colleague William Breitbart, who has recently introduced me to the work of Karl Jaspers, who I've been reading as of late. I don't claim to be completely conversant in Jaspers' work, but my paraphrase of my understanding of Jaspers' definition to existential distress essentially says that it is something that manifests when we're confronting limitations that interfere with being able to express or sustain who we are, or it interferes with our being authentic in any aspect of our existence. So when suffering begins to take the form of that it interferes with our ability to be our authentic self, existential distress ensues. And therefore, we start to see things like hopelessness or demoralization, which is a combination of hopelessness, loss of meaning, existential distress, with the end result being loss of will to live, and therefore perhaps requests for hastened death or MAID. So it may not be a perfect model, and it may be a model that requires some tweaking, but at the very least, my reason for including it is that perhaps it begins to provide some kind of an existential map that we can use in trying to inform whatever research agenda or clinical approaches that might result from today's meeting. So in response to that kind of understanding, our research group has done a number of things to try and address suffering in the context of life-threatening or life-limiting conditions. So for example, if we understand that personhood an assault of personhood is a source of suffering. One of the studies that we've done and reported on, and now it's being kind of replicated in it by a number of investigators. There was a recent study of several thousand patients who at Memorial Sloan Kettering who actually were administered what I call the patient dignity question. What should I know about you as a person so I can give you the best care possible? And it's essentially a way of being able to elicit in a brief way a story that focuses on personhood. In terms of the study, we have a brief conversation which we summarize. We go back to the patient, we read it, we affirm whether or not it's accurate, and then the litmus test, do we have permission to place it on their clinical chart? Because if we're going to influence suffering, then, and we take seriously the fact that the way we, the healthcare provider, see that individual has an influence on suffering, we need to be able to do something that changes our perception. This is just a brief example of a patient dignity question response from a First Nations woman who told us in the context of approaching end-of-life care, and I remember seeing her on the palliative care ward at St. Boniface Hospital, that she'd moved 82 times so as not to let anyone get too close, that things have gotten better over time, but she still has struggles with being able to trust people. She wants to, it's hard for her. I remember her telling me that people in white coats frighten her. She thinks that people might not see her as being deserving of being told the whole truth. And while she appreciates people being friendly with her, she's frightened of authority figures. And so I share this to say, how can we claim to begin to address the suffering of patients that are in our care in the absence of knowing even these profound and fundamental issues with respect to what defines them as a person? So we need to put personhood and ways of eliciting personhood on our clinical radar. And just again, because there's not a lot of time, to say that when we've asked patients their response to the patient dignity question, invariably it is accurate. They say that it's important, nearly 100% say this is important information for their healthcare provider to know. They feel it will affect their care, and all of them would recommend it to other patients. And indeed, when we then get information from healthcare providers, what we find out is that in 90% of instances, they learn something new that they didn't know about this patient previously. And even this brief 5 to 10 minute conversation being placed on the chart starts to have an influence on things as profound and fundamental as their respect towards the patient, issues around empathy and connectedness. This is the model of dignity at end of life. And again, because of time, I'm not going to go through it in detail, other than to say it's empirically based. It begins to give you elements that are related to the undermining of sense of dignity. And because we know the connection between dignity and loss of will to live, I would suggest to you that this begins to provide an empirical map that starts to say these are things that we need to be mindful of if we're going to have a holistic approach to addressing suffering. Are there ways of being able to measure that? We've heard earlier speakers say that some of the instruments that are available are limited. The ESAS is certainly a good instrument, but unlike the ESAS, I mean, we have, on the basis of the model of dignity in the terminally ill, devised an instrument called the Patient Dignity Inventory. So these are 25 items that include the physical, the psychological, the spiritual, and the existential. So it's not enough to ask patients who are contemplating no longer wanting to go on, are you in pain? But we need to ask, for example, if we look at question number 11, no longer feeling like who I was. This is a profound existential question. And if we're really serious about trying to understand what moves people towards no longer wanting to be here, we need to understand more than their pain or their last bowel movement. We need to understand whether or not they fundamentally still feel like they're a person and a person who has value. A new instrument is a bit like, having a new microscope or telescope. You can see things that you couldn't previously see. Again, because of time, I'm not going to spend a lot of time going through this, other than to say that you can begin to see this kind of landscape of issues that patients near end of life identify. And they're very close to some of the ones that we talked about when the Health Canada data were shown from the last report amongst patients requesting MAID. So not being able to participate in usual activities, distressing symptoms. But again, nearly 40%, not feeling like the person that I once was. I think I'm going to skip these to go to the Health Canada data, which we've seen a number of times. Again, I would point out that although we've had discussions about palliation and the adequacy of palliation, it seems to me there's a whole lot more work for us to do in this and to really unpack it, because even if we can convince ourselves that many, many patients are having access to palliation within the last few weeks or months of life, the truth is that, suffering is a bit like cancer, and the longer it's left unattended, the larger it grows and the more it metastasizes, so that by the time we see people in the last month of life, trying to get hold of suffering is like trying to get hold of a metastatic illness that has failed to be identified in the early stages when it might have been amenable to treatment or to be prevented or even cured. I know there's been some discussions about the fact that, can we really treat existential distress? Is there any treatments for existential distress that are effective? And although it's been suggested that we have nothing that really works, I guess our group failed to get that memo. I've been involved in palliative care and palliative psychiatry for several decades. One of the things that I, along with my colleague William Breitbart, have done is to publish a handbook on psychiatry. These are the first 3 editions. The 3rd edition will be coming out in November. And one of the things that I would kind of point out, I've just to show you a portion of what's contained in that textbook. And again, the entirety of psycho-oncology and palliative psychiatry in various different ways is looking at how can we address suffering for people whose lives are being threatened. But if we just look at the psychotherapeutic interventions, here are 11 chapters of various different approaches that are being used, that have empirical support to suggest that they have efficacy in terms of their applications at end of life, or people who have life-threatening conditions. Certainly, there are a few of them that have been specifically designed for palliative care. So meaning-centered psychotherapy has certainly been shown in randomized control conditions to mitigate depression, anxiety, and desire for death. Calm therapy by Gary Roden and his group has been shown to lessen prevalence of depression, to decrease death anxiety. And dignity therapy, which I'll say a little bit more about in a moment, has also been shown to influence end-of-life experience and in distress populations to mitigate desire for death and demoralization. I pulled this out after hearing some presentations today that cited meta-analyses that suggested that these existential approaches may not have any impact. The most recent one that I could find in the interval that I had between the break and adding this slide at the last minute was published in 2018. This was summarized in, there was a special issue of Psycho-Oncology, Veiling and Kassane, and the most recent meta-analyses that they refer to as one of 30 RCTs, looking at existential therapies, predominantly in patients with advanced cancers, looking at things like supportive expressive therapy, CBT, dignity therapy, meaning-centered psychotherapy, calm therapy, life review, narrative, hope and meaning interventions. They show small to moderate pool effect sizes, and then they conclude that there are clear benefits that are arising from these existentially oriented psychotherapies. I could say a lot about dignity therapy, but I think I'm almost out of time. But it's simply to say that it's one example of the kind of intervention that I think we can be thinking about, at least to try and mitigate a sense of therapeutic nihilism. The fact that people who are suffering, and in our earlier studies, we found that, I mean, about half of all patients, when you ask about desire for death, half of all patients at some time in the course of approaching death will express a desire for death. So desire for death is an expression of anguish, of suffering, and it requires an approach that means we engage in conversations that try and unpack what that is about. And at this point, there have been about, there are about 100 papers in the literature. There are 8 systematic reviews of dignity therapy showing that it seems to impact end-of-life experience, and in particularly distressed populations, that it mitigates desire for death and demoralization. So the last 2 quick things, and really they're kind of a repetition of things I've said earlier in the talk, and that is to say, I think if we're going to try and enrich and expand this conversation, we need some kind of theoretical or conceptual framework that looks at this kind of experiential landscape of suffering. To confine ourselves simply to MAID without considering the context of MAID, I think is really to kind of give short shrift to the importance of these questions. I mean, people are suffering, and we need to try and understand that, and we need to try and understand various ways of approaching that. And finally, to say again, MAID cannot be our only card, and hopefully by sharing this with you, it at least has begun to look at various other cards that we, I think, in a fairly vigorous way, are currently holding in our deck. So thank you for that.